Assalamu alaikum. I am Dr. Ali Rabbani, Assistant Professor of Anatomy, and today we are going to continue with the topic of brainstem. And now we are going to discuss the pons, the cross-sectional anatomy, the internal anatomy of pons. This is a lecture in the series of our lectures in neuroanatomy. You can find all of these in our Facebook page or in our YouTube channel, Medicals Academics. Okay. So, as we have already gone through the external features of the brainstem, this is the pons, and it is called pons because it literally means the bridge. So, it is made by these, the bridge is made by these horizontally running fibers between these two halves of the cerebellar hemispheres, and so this area from this pontomedullary junction to all of this superior pontine sulcus, this is the pons. Okay, and here for the cross-sectional anatomy we are going to have two cross sections. One cross section is at the level where cranial nerve number 5, the trigeminal nerve, is exiting, and here the main trigeminal nuclei are present. So our first cross section will be at the level of the trigeminal nuclei, and our second cross section will be at the level of facial colliculus where abducens and facial nuclei are present. It's not visible externally as these nerves are exiting at pontomedullary junctions, abducens, facial, vestibulocochlear, but we will see them nonetheless. So these are our target cross sections that we are going to discuss. I would suggest you to draw with me. Take out your, pause the video right here, take out your pen and pencils and draw along with me. And these cross section anatomy, if you have a very good idea of the map, they will help you tremendously when talking about the syndromes and when you're trying to find out the lesions and their effects. So let's start with the basics. I have left the external anatomy picture here so that we can give reference to it from time to time. So let's start from the basic structure. So this picture, the superior one, is at the level of trigeminal nucleus and trigeminal nerve, and the lower one is at the level of facial colliculus. As you already remember, this is the anterior aspect, this is the pons, this is the base of the pons, and these horizontally running fibers are there, so you can see it right here. And anterior aspect, there was a vertical groove for the placement of basilar artery. This is shown like here, and behind the pons there is the fourth ventricle separating it from the cerebellum. So behind the pons here, the fourth ventricle is shown right here, and we will see further things as we move along. So this is the groove for basilar artery here anteriorly, where basilar artery is made by union of two vertebral arteries. The two vertebral arteries run right here in front of the medulla oblongata. They join together and they form the basilar artery, and where the pons end, they divide again into two posterior cerebral arteries. So basilar artery, interestingly enough, is only long enough as the size of the pons. At the lower border of the pons, it is forming. At the upper border of the pons, it is ending by dividing into posterior cerebral artery. What are the branches of vertebral artery? What are the branches of basilar artery? That is not our current topic of discussion. So let's start with our topic, continue with our topic right here. So behind the fourth ventricle, this is superior medullary velum. Superior medullary velum is basically the part where two superior cerebellar peduncles, they join with one another, right? It's called superior medullary velum. You will see this thin connective, this bridge between two halves on either side of the fourth ventricle. This is superior medullary velum. As you already discussed, this is the fourth ventricle. So corticospinal tract. Here, in addition to the corticospinal tract, I will also use the term corticobulbar tract, because this is the corticospinal tract that was coming from the cerebral cortex, from corona radiata, internal capsule, cerebral crus cerebri, and it is running from anterior aspect here in the midbrain, pons, medulla, and decussate, and it went down. So this is the part that we are looking at now. So it not only contains the fibers that are going to supply the muscles of the limbs, these are also going to give the fibers that are going to supply the cranial nerve nuclei. For example, hypoglossal nuclei was exiting here. So in addition to the corticospinal tract, we will also call them, it will also contain corticobulbar fibers or corticonuclear fibers. These will be also present because these are the fibers that are starting from the brain and are going to terminate in the relative part of the relevant part of the brainstem, where they are going to supply the cranial nerve nuclei. In the medulla oblongata, you saw it joined as pyramid. In the midbrain, you will see it together in a crust. In pons, you will not see them aggregated together. They are little spread out, the corticonuclear fibers and corticobulbar fibers, because they are little spread out because of these horizontally running fibers that, like, these fibers are coming here and horizontally fibers are going like this. So they separate the corticospinal and corticobulbar fibers, this tract. And the importance of this is that this tract is spread out on a more area, so a smaller injury, the same size injury, will affect a lesser area of the corticospinal tract as compared to it would have been damaged in the medulla oblongata, where the tract was very condensed place together with close one another. So this you can see from the A part, and the same you will see in the lower aspect, they are passing down. So that is the corticobulbar fibers, and that will be true for both sides. Next, let's talk about pontine nuclei. Pontine nuclei are a part of a circuit through which cerebral cortex communicates with the cerebellar cortex. So the signal from the cerebrum comes down to the internal capsule, crus cerebri. Here, this synapse with pontine nuclei, and after connecting with the pontine nuclei, the axons of these pontine nuclei, they go across the midline and go to the opposite cerebellum. Actually, this horizontal run of all the fibers in the pons, these are majorly made up of these axons of the pontine nuclei. So this tract was basically cerebro, this ponto, this cerebellar tract. So this was the pathway through which cerebral cortex was communicating with the opposite sided cerebellar cortex. So these are the pontine nuclei that you will see. They will be present in the upper part also, they will be present in the lower part also. And if you have gone through the lecture of the medulla cross section, you saw arcuate nuclei. Those were exactly the same thing. The arcuate nuclei were the pontine nuclei that were placed lower than pons in front of the medulla oblongata. These are pontine nuclei, and they will give rise to the pontocerebellar fibers, and they will cross the midline and they will go to the cerebellum. And these fibers, these are transverse pontine fibers, pontocerebellar fibers that are a part of the cerebropontocerebellar pathway, and that's not exclusively them. Some other tracts may also be contributing here. And the part where all of this bundle joins with a cerebellum, this bundle, this is called middle cerebellar peduncle. This is the middle cerebellar peduncle. So through this medulla oblongata, through this pons is communicating with the cerebellum. So you can draw the same pontine fibers on the opposite side too. Next, other peduncles, superior and inferior cerebellar peduncles. I know you have studied that the superior cerebellar peduncle joins midbrain with cerebellum, the middle one pons with cerebellum, and the inferior one joins the medulla oblongata with cerebellum. But these converge at the level of pons. The superior cerebellar peduncles come down and join the cerebellum. Middle cerebellar peduncle go like this to the cerebellum. From below, the inferior peduncles go up and join the cerebellum. At the level of pons, you can actually see both of these, inferior cerebellar peduncles and superior cerebellar peduncles. In the lower section, the section at the level B, you will majorly see inferior peduncle, and majorly at the upper one and also somewhat at the lower one you will be able to see the superior peduncles too. So you will draw the inferior peduncles just anterolateral to the fourth ventricle right here. These are peduncles, and posterolateral to it you will see superior cerebellar peduncles. So these are the two peduncles. So one picture of the pons will contain all three: middle, inferior and superior cerebellar peduncles. In the upper section shown in A, you will be only able to see superior cerebellar peduncle, and as compared to this picture here, they are a little more prominent. These are superior cerebellar peduncle on the back. Next item on the list, that is trapezoid body. Trapezoid body, there are some nuclei by the same name, trapezoid nuclei, and the axons of those nuclei, and that will include also the axons from olivary nucleus that cross the midline. These are actually the track of the auditory system. The signal that came from your ear, from the spiral ganglion, relayed in cochlear nuclei, and from there it relayed in trapezoid or olivary nucleus and cross the midline. Some cross the midline first and then fuse that. So those crossing fibers, they make the trapezoid body. You will see trapezoid body in both of the sections. These are horizontally crisscrossing fibers and that are related to the auditory pathway. By the way, this trapezoid body that divides pons into two parts: the part that is behind the trapezoid body and the part that is ahead of the trapezoid body. That is true for both of the sections. The part I'm demarcating line I'm assuming like this, and the one that is in front of it. So the part that is behind it, this is called tectum. This part, not tectum, this is called tegmentum. This is called tegmentum, and the anterior part is called the base of pons, pontine basilis, or something, some derivative of the word that you will find. So this part anterior to it, that contain the corticospinal, corticonuclear fibers, the pontine nuclei, the horizontal transverse running pontine fibers. So these are all part of the base, and behind it all of the other nuclei along with the cavity. This is the tegmentum. Okay, now let us start with the sensory tracts. Sensory tract, the first one that you are going to see is the medial dorsal column medial lemniscus system. It started in the spinal cord, came up in the medulla, it relayed in nucleus gracilis or cuneatus, crossed at internal arcuate fibers, ran up at medial lemniscus, and as it goes up, it gradually moved towards lateral aspect. And this is what you are seeing in these two pictures. The medial lemniscus right here. So you will see medial lemniscus right here. So this is what you are seeing right now. That is medial lemniscus. The next one is spinal lemniscus. Some books also add trigeminal lemniscus, but let us move it to it gradually. So there is, let's first talk about the spinal lemniscus. Spinal lemniscus is the lemniscus that is, spinothalamic tract. So it started here, ended in the spinal cord, crossed the midline, came all the way up. It is present later to the medial lemniscus. So you will see it right here. I have not have already drawn it here, but additionally some books also add here trigeminal lemniscus. Trigeminal lemniscus. As you can see, by the name trigeminal lemniscus is the lemniscus coming up from the trigeminal nuclei. Spinal nuclei of the trigeminal nerve, the second order neuron that are arising from that spinal nucleus, they will cross the midline and they will travel up, that we call trigeminal lemniscus. Then there is lateral lemniscus. Lateral lemniscus is basically the auditory fibers that are going up after crossing the midline in the trapezoid body. You got the signal from the ear. Here is the vestibulocular nerve. There was in the spiral ganglion bipolar cells in the ear. It enter here. After entering, it synapsed here with the cochlear nuclei. After synapsing or without synapsing, they cross the midline. Some cross, some don't cross. Both are true here. And here they cross in the trapezoid body, and after crossing they move up, and this moving up, this is called lateral lemniscus. We will see it further in the auditory pathway when we will discuss the cranial nerves. Actually, that video is available if you search it by the name of Medicos Academics. The same tracks can be traced on the upper section, that is medial lemniscus, then spinal lemniscus, and then lateral lemniscus. I might add, you can add here between medial and spinal lemniscus, you can add trigeminal lemniscus. You can add trigeminal lemniscus. That's it. Moving on. Next cranial nerve, that is the abductor nerve. Abductor nerve cranial nerve nucleus is present posteriorly relatively near to the midline, and it is the cranial nerve number 6, and its fiber moves anteriorly and exit from the pontomedullary junctions, as you can see right here. They exit from the pontomedullary junction, and they are going to go and abduct the eye through lateral rectus muscle. Facial colliculus. Now this is an interesting phenomena. For the start, let's not focus on the 3 nuclei present here. Let's consider it a single nucleus, facial nucleus. Facial nucleus, after giving rise to the facial nerve, it does not simply exits like this. No, it does not occur like this. The nerve that goes and circles around the abductor nerve. So this whole circle, as it going around, this circle is called facial colliculus. Facial colliculus, and if you remember from the discussion of the external anatomy, facial colliculus, this raised area was visible on the posterior aspect of the brainstem when we were looking through the fourth ventricle. And very clinical significance of this is that due to this intimate relation between the facial nerve fibers and the abductor nerve nucleus, any injury that is injuring the abductor nerve nucleus will one way or another involve facial nerve also. So any injury that is affecting this nucleus will affect facial nerve also and its area of supply. So this is facial nerve, and before going further, let me show you the other nuclei that we have drawn. In the red, you have drawn the facial nucleus, the main motor nucleus that is going to supply, that is the special visceral efferent fibers that are going to supply all the muscles of the face, muscles of the facial expressions, the platysma muscle and the muscle that are present posterior belly of digastric and skull heart, all of the muscles that are supplied by the facial nerve, the supply comes from this facial motor nucleus. Then in the second red nucleus I have drawn is superior salivatory nucleus. Technically there are 2 nuclei here. The true nuclei that are here, these are superior salivatory nucleus, and then there is lacrimatory nucleus. The superior salivatory nucleus is going to supply sublingual and submandibular glands through submandibular ganglion, and lacrimatory nucleus is going to, as you can guess by the name, lacrimal gland through pterygopalatine ganglion. So these are the supplies. These are the areas that are going to be supplied by it. The superior salivatory nucleus is going to make your mouth salivate through the sublingual and submandibular gland. And then there is lacrimatory nucleus that is going to supply the parasympathetic fibers need to give the tear in the eye, the lacrimal gland that is going to be functioning through that, and it goes to pterygopalatine ganglion. And then there are sensory fibers too. The tongue, as you can, the tongue, anterior two-third of the tongue, the taste fibers are going back to the brainstem through facial nerve, and this taste fiber, special visceral afferent fibers are going to reach the consciousness through this solitary nucleus. So these are the three nuclei that were made. You can name it as facial nuclear complex or anything that you can see. So that is about the facial nerve. Let us talk about the cochlear nerve, cochlear nucleus. Their relation is very similar to the one that was present in the medulla oblongata. That dorsal and ventral cochlear nuclei are present dorsal and ventral to the inferior cerebellar peduncle. It is the same relation that was present here. Vestibular nuclear complex. Majorly it consists of here superior vestibular nuclei, very similar to that of the medulla oblongata that were present on the medial aspect of inferior cerebellar peduncle. There is rubrospinal tract. The rubrospinal tract is a tract that starts from the red nucleus in the midbrain. In the midbrain, it crosses the midline. Then near the midline, it descends down and not near the in the brainstem. It's near the midline, but as we go along, it will move laterally and it will be traveling with the lateral corticospinal tract eventually in the spinal cord, and that is going to increase the flexor tone of the muscles and decrease the extensor tone of the muscles. Then there is tectospinal tract. Tectospinal tract is another of the cross pathway, and it starts from the superior colliculus in the back. It's not visible from the front, and they are superior colliculus, the fibers, they come cross the midline and go down in the anterior white column, and it is going to for the reflexes, the visual reflexes. When you see some light and you turn towards it, that is the due to the tectospinal tract. Then there is trigeminal nucleus. Trigeminal nucleus system, it consists of four nuclei, three sensory and one motor. At the level of Pons, there is main motor and main sensory nucleus. Below the pons into the medulla and into the upper part of the spinal cord, there is spinal trigeminal nucleus, and above pons into the mesencephalon into the midbrain, there is mesencephalic nucleus. I will shortly go through that too within this very lecture. So medial, you can see medially present motor nucleus, main motor nucleus. It supplies all the muscles of mastication. The two muscles that are present here, that are the anterior belly of digastric and mylohyoid, and the two muscles that have the name tensor in them, the tensor veli palatini and tensor tympani. And this main sensory nucleus, it receives the discriminatory sensory sensations, two-point discrimination, texture from the ipsilateral head and neck. And then there is spinal trigeminal nucleus. I discussed it a little more in the medulla oblongata cross-section lecture. You can refer to that. Then there is medial longitudinal fasciculus. We also saw that in the medulla oblongata. This is a tract that is traveling near the midline, that is traveling very much near the C subcontaining cavity, here the fourth ventricle, and that connects all of the three nuclei that supplies the extraocular muscles, cranial nerve number 3, 4 and 6, and joins them with the vestibular nuclei, with the cochlear nuclei, and with the musculature of the axial skeleton. And so different vestibulo-ocular and other reflexes are maintained through it, and they help in work in conjugation with one another. Then there is reticular formation, that is the diffused network of cells and fibers that are present behind them, and it contains many nuclei for different reflexes, especially related to viscera, and the upgoing fibers are very important in keeping your brain awake and to maintain the arousal of the brain. So that's it. That's the cross section of the pons. You can pause the video here, take a screenshot if you like it, and if you have any question you can mention it. But before I close the lecture, I would like to discuss two topics. First is a trigeminal nucleus. Trigeminal nuclear complex is a very complicated complex. It consists of four nuclei. The first is the main motor nucleus. It's present medial to the main sensory nucleus, and it exits and it supplies the muscles of the mastication plus four other muscles that include two muscles with the name tensor in them, tensor villi palatini and tensor tympani, and two that are present here below chin, you can say, anterior belly of digastric and mylohyoid muscles. So that's that. Then there is main sensory nucleus. This is the main sensory nucleus. It receives the tactile, the pressure, the 2-point discrimination sensations from the area of supply of the trigeminal nerve, that is most of the head region and some of the neck region too. So here they are repeated separately: face, scalp, oral cavity, nasal cavity, and dura. Third is the spinal trigeminal nucleus. That is the downward extension of this nucleus that goes all the way down to the upper segments of the spinal cord, and from the same area of supply, that is face, scalp, oral cavity, nasal cavity, and dura, these nucleus receives the pain and temperature sensation. So that nucleus is equivalent to the substantia gelatinosa in the spinal cord. And as you can see, the nerve enters at the level of pons, but to reach the spinal nucleus, it first descends and then synapse. So these descending fibers, these are called the spinal trigeminal tract, and you have drawn these with the pictures too. And last but not the least, these are mesencephalic nucleus that is going up into the midbrain, the mesencephalon, and it receives the proprioceptive fibers. And here one very interesting thing, if you can notice here, in most of the cranial nerve sensory nuclei, what happens is that there is a first order neuron that is present outside the CNS, like this, in the case of spinal nerve, in the dorsal root ganglion, and in the case of cranial nerves, it has their own ganglion, like trigeminal ganglion, and they enter and synapse with the sensory ganglion cell. That is usually the second order neuron, the main and spinal. But in the case of proprioceptive fiber, this is the first order neuron. This is the pseudo unipolar neuron. You can see there is no pseudo unipolar neuron outside, and according to the board review series book BRS, this is the unique and only instance of pseudo unipolar neuron present inside the CNS, and that is for proprioception, and that is responsible for jaw jerk reflex too. Like when you hit here, the muscle spindles activate and the signal comes here. Monosynaptic reflex is connection is made with the main motor nucleus that leads to the muscles of mastication, leading to the closure of the jaw. So trigeminal nerve is responsible for the jerk reflex. Now the next thing, I want to discuss the difference between the corticospinal tract and the corticobulbar or corticonuclear tract. In this picture, for now, don't focus on it, focus on this. In corticospinal tract, the signal, it starts from the cerebral cortex, the upper motor neuron. Corticospinal tract moves down. The disc is set at the level of spinal cord and medulla oblongata junction and goes down and supplies the lower motor neuron, and it supplies the muscle. The important thing is the signal started from the right hemisphere and ended at the left sided muscle, and vice versa for the other side. So any stroke of the brain on the right side will lead to the paralysis of the muscles, the upper motor neuron type paralysis on the left side. However, in the cranial nerve nuclei, or rather in most of the cranial nerve nuclei, that is not the case. The any lower motor neuron, let's take for instance, this is trigeminal motor neuron. So it is supplied by cerebral cortex from both sides. It is supplied by the cerebral cortex from ipsilateral side and the contralateral side too. What is the importance? For example, a person has a stroke. At right side, its cerebral hemisphere stopped working. Then this signal stopped and contralateral skeletal muscle, the contralateral limb muscle will go under paralysis. However, even with the absence of this corticonuclear fiber input, this input from the same side is okay. So this muscle, this cranial nerve nuclei will remain okay. So apart from those exceptions where only a contralateral supply is present, most of the cranial nerve nuclei are not affected with the stroke of one side because that is compensated from the other side. So the exception is the part of the facial nerve nucleus that supplies the lower half of the face and the part of hypoglossal nucleus that supplies, please don't mind my language or writing, that supplies genioglossus muscle. So these are the two things, the genioglossus supply and the lower half of the face supply. These are the supplies that are maintained by only contralateral cerebral cortex. All the other cranial nerve nuclei, at least cranial nerve motor nuclei, are being supplied bilaterally. And now you can see all the list here. Muscles of mastication supplied bilaterally, muscles of facial expression partially bilaterally, muscles nucleus ambiguous that supply palate, pharynx and larynx, and tongue except genioglossus, the muscle responsible for protruding of the tongue, and accessory nerve, the spinal accessory nerve, all of these muscles are supplied bilaterally with the two exceptions. So here I am going to discuss that exception with you. This is a picture from Kaplan's neuroanatomy. Here is the facial nerve nucleus and it is shown to supply the muscles of the face, the muscles of the facial expressions. It leads to the wrinkling of the forehead, it helps in the shutting of the eye, it helps in the making of this nasolabial fold, it helps in the closing of the mouth and helping you smile. Or if that muscle paralyzes, you will see absence of wrinkling, you will see failure of closing of eye leading to dryness, you will see absence of nasolabial fold and inability to flare the nose, and you will see inability to close the mouth. If a person drinks fluid, he or she will leak from affected side. So that is the lower motor neuron. Okay, now this nucleus has been divided into two parts. The lower part that is going to supply the lower half of the face, the upper part that is going to supply the upper half of the face. Let us focus on the upper half only. The upper half that is supplied by the upper motor neurons from both sides of the cerebral hemisphere. However, the lower half is only supplied by the upper motor neuron from the opposite side. What does this mean for a person with an injury? I will discuss this first. If there is a stroke on one side, this part, the lower half of the face, will become non-functional because this was interrupted. The corticonuclear fiber coming from the contralateral side were affected. However, for the upper half, the contralateral corticonuclear fiber were indeed affected, but the ipsilateral were fine. So the upper half of the face, this nucleus keeps on working. So a person with the stroke anywhere above the pons, that person has normal upper half of the face, there is normal blinking, there is normal wrinkling, but there is abnormal lower half of the face there will be absence of nasolabial fold and failure of closure of the mouth on the affected side, and the healthy side will pull the lips toward itself. That is the upper motor neuron lesion. Any lesion that includes the facial nerve nucleus itself or the facial nerve axons in any subsequent way. Any injury in the pons that affects the nucleus, any injury in the internal acoustic meatus, pontomedullary junction, inner ear, middle ear, sternum foramen, parotid gland, anywhere, this is the lower motor neuron type lesion. Whenever you are confused whether the axon I am talking about is lower motor or upper motor neuron, just ask yourself this question: is this the last neuron on the way to the muscle? If it is, then that is the lower motor neuron. Here it is the last neuron on the way to the muscle. That is the lower motor neuron lesion, and that is the lower motor neuron lesion is known as the Bell's palsy. And when lower motor neuron is affected, is it usually affected as a whole? There is no preference for upper and lower half of the face. So in case of lower motor neuron type palsy, there is flaccid paralysis of the complete half of the face. So that's another way you can differentiate between the upper motor and lower motor neuron type lesion. In the upper motor neuron lesion, you will see contralateral loss of the lower half of the face. In the lower motor neuron type lesion, you will see ipsilateral paralysis of the complete half of the face. And the same story holds true for hypoglossal nucleus that supplies the genioglossus muscle. Okay, so that's it. That's about the Pons. I hope it was helpful for you. If you have any suggestions regarding this topic, you have any questions, you have any feedback that you would like to share, please do mention in the comments, and do follow us on our social media handles so that you can get updated for our new upcoming lectures. And our next upcoming lectures will be the clinical lesions of the pons and the cross-sectional anatomy of the midbrain. We've already discussed the general anatomy and the medulla oblongata and the spinal cord and all the ascending descending tracts and the lesions. And if you are interested, please do follow us on our website medicosacademics.com, our Facebook page, our YouTube page, all are by the names of Medicos Academics. Our contact information is given here. Thank you so much for listening, and stay tuned till next time. Allah Hafiz.